Hello and welcome. My name is Dr. Eliana Ramirez. I am the director of the CARE Crisis and Recovery Enhancement TA Center. I am so excited that you're here for a cohort coaching session with Mr. Jamie Seller, who's the Chief Strategy Officer of RI, Recovery International. We are today going to be talking specifically about key performance indicators. Next slide, please. So just to begin, we start always with a disclaimer. This project is funded through the Mental Health Services Act as administered by the California Department of Healthcare Services. I work at the Center for Applied Research Solutions. What we are about to say here, while we are very grateful for the funding and the institutional support, what is about to be said here does not necessarily represent the funder or the organization where I work. Next slide, please. CARE is the Crisis and Recovery Enhancement TA Center. We provide no-cost training and technical assistance to the 58 MHSA-funded counties and 2 city jurisdictions across the state of California, specifically to provide evidence-based and culturally responsive, trauma-informed crisis continuum of care and justice diversion. Our CARE TA Center is a collaboration of several subject matter experts regarding the crisis continuum of care and justice diversion. You can see here Recovery International, RI, National Association of Mental Illness, California chapter, C4 Innovations, Research and Action Center at Impact Justice, and Stanford Youth Solutions. So our audiences, as I mentioned, predominantly are the counties. There's 58 counties and 2 city jurisdictions. Let's move forward, please, to the next slide. We also serve community-based organizations. We have a variety of training and technical assistance. If you're not familiar with our services, we encourage you to go to our website where you can submit a request for no-cost training and technical assistance. And you can access a variety of resources from a resource library to a county asset map. You can put in your local zip code and find out what are those crisis care and justice diversion programs in your county and neighboring counties. Next slide, please. As I mentioned, we're collaborative. We focused on evidence-based practices and culturally appropriate services. Next slide, please. I am now going to invite Mr. Jamie Seller to take it away, please, sir.
Appreciate the time today. Really gonna do an in-depth conversation and really talk about how key performance indicators really are going to start to drive what your service delivery system is. But I'll start by introducing myself. I know a lot of people have been on these calls in the past, so I won't go too far. My name's Jamie Seller. I am the Chief Strategy Officer at RI International, which is a beautiful title, but really what it means is I get to do consulting, business development, and training, both nationally and internationally, really around the crisis space. My background is as a licensed professional counselor. I was certified in the state of Arizona long before licensure was even a requirement, before it was a thing where you become a certified professional counselor. And then in July of 2004, licensure then became mandatory. I was able to go ahead and grandfather in. But really at my core, I've worked for the last 30 years or so in crisis, hospitals, crisis facilities, outpatient crisis centers, call centers, mobile teams. Near and dear to my heart is actually working with mobile teams. I was fortunate enough for years to be able to run the mobile teams here in Maricopa County, which are seen as kind of the exemplar. The Crisis Now model was built on the back of the work that was happening in Maricopa County for crisis teams. And for those of you who know, SAMHSA's national guidelines came out of that Crisis Now white paper that came out in 2016. SAMHSA's guidelines basically look almost identical. And part of the reason it looks almost identical is because RI International, the agency I work for, was a lead agency in writing SAMHSA's national guidelines. I was fortunate enough to be one of those writers, and I actually wrote a lot around mobile teams based on my experience here in Maricopa County, where we were running 24 mobile teams a day. Each mobile team would be 10 hours. We take a look, that's about 960 hours worth of coverage per week. I often look at at teams in terms of coverage, which is about 137 hours worth of coverage a day. So, at any given time, we might have 5 to 7 teams up, or we might have 1 or 2 teams up at 2 o'clock in the morning. So I'm going to start talking really today about key performance indicators. I'm going to review really what SAMHSA, what those national guidelines talk about with key performance indicators. And quite frankly, in SAMHSA's guidelines, we wanted to keep it fairly brief. Most people don't really lean into the data. We knew if we made it too complex, it might be problematic. So I'm going to then talk about what SAMHSA's recommendations are for key performance indicators, but throw in my own spin as well, things that if I was running an agency that was operating mobile teams, or if I was a funder, that I would definitely want to be working through. I want you to help understand the national benchmarks and how to adapt them to your community. There's going to be a huge difference in what you may be seeing if you are working in frontier, rural areas versus urban areas, and how a lot of times some of your outcomes are going to be really dependent on what community resources there are once you've actually seen somebody, if you can help them stabilize, remain in community. And then basically just a few tips of somebody who's been there and done that, on really what you can expect, how you can start to make those changes, how you can either start to bring systems up or try to optimize systems that you've got, and the challenges you run into, trying to move your meters just a little bit, trying to move that dial 2 or 3% sometimes can feel Herculean. We'll talk a little bit about what's easy to move, what's low hanging, what's high hanging, and we'll kind of go from there. So let's go ahead and we'll move forward. Really what I wanted to do, we're going to keep going if we can. There we go. This is just, I'm going to go over this very quickly. This is what SAMHSA says a mobile team does. It includes a licensed credentialed clinician that's capable of assessing the needs of individual. Advanced practice would be a 2-person team, and that second person should be a certified peer support specialist. It should respond to where the person is. I talk about we need to go where people live, work, and play. We need to actually have a street level response. If my mobile teams are only going to the emergency department to do level of care assessments, still helpful, still meets a little bit of that community need, but it's not really truly a mobile crisis outreach team. I could go ahead and embed a clinician in the ED to go ahead and do that work. I don't have some of the same challenges if I'm doing street level work. They should be able to connect individuals to facility-based care, and they should coordinate transportation as needed. In various other parts of these trainings, we'll talk about transportation. Should incorporate peers within the team. Should respond without law enforcement unless special circumstances warrant. Should utilize the technology to go ahead and improve and optimize what their system looks like, and really should coordinate care, including schedule outpatient. These are the things that you do that really mobile teams are really kind of built for. So what is a mobile team? This is what mobile teams are doing. But once again, we've talked about this in the previous 2. We'll talk about this a lot in the upcoming sessions, but we're really going to talk a little bit more about what the key performance indicators are if we move forward. So I want to talk just about the need for key performance indicators. So part of my role that I get to do as a consultant is I've probably been in a dozen states in the last 2 to 3 years. And everybody has me taking a look at mobile teams. I also look at facility-based services. I also look at call centers. I also look at ACT teams and a couple of other system design issues or system design elements that really support crisis services. Can't tell you how many counties I've been, how many EDs, how many times I've talked to local law enforcement, how many times I've worked with mobile teams or facilities. But the key is I always start off with the same question. My question always is when I'm working with a mobile team is, hey, do you have a good program or not? And invariably, I get almost the same answer. It's always yes. There've been a very few times, but it has happened where they say no. But they'll say, yes, I've got a good program. And I ask, okay, so tell me more about that. How do you define what a good program is? How do you define what success is for your teams? And invariably, what I am going to say, predominantly, they're going to start trying to appeal to my heart. They're going to start talking about, well, we do good work. We'll meet anybody, anytime, anywhere. And we're dedicated and we'll do whatever it takes. And we've got really dedicated clinicians that are out there. And we know the community resources. And we work with the most vulnerable in the population. Hey, I'm a licensed professional counselor. I eat that up. But what I know when I start to hear those things is that they're not keeping track of bigger amounts of data. They can't tell me if they're doing good or poor. They've got nothing to benchmark it against. What they do know is they're doing work that makes them feel good and invariably does help the folks that they see. but they don't know if they're efficient. They don't know if they could get better. They don't know what that would actually even start to mean. So when we start talking about key performance indicators, the one thing I want to talk about is as you are looking at these key performance indicators, they should be able to give you a hint as to the strength, as to the value, as to the capacity, really of your mobile teams. But what I like to think about with key performance indicators is it always indicates for me areas that I'm strong, areas that I'm weak. And if I do it in a fearless and transparent way, I'm going to be improving each month what my outcomes are for the community. So when I do talk to a mobile crisis outreach team, program, a supervisor, manager, director, executive director of the agency, and they start to tell me about how many people they've seen, what their community stabilization rates are, what their transports to higher levels of care, how many folks are putting on 5150s, I can sit there and I can start to say, invariably, I know that those programs probably are stronger than the ones that are talking to me about how they helped, Jamie, 6 months ago when he was in a crisis. So it really is going to be how we define success. And just think internally, when people ask you to describe what you're doing, are you talking more about antecedents, anecdotes, or are you really talking about data? So quite frankly, I will change how I talk depending on who I'm talking to. So if I'm talking to community stakeholders, I may bring in a few of those, anecdotes to go ahead and talk about the work we're doing. If I'm talking to my funder, if I'm talking to my regulators, if I'm talking to somebody that's going to be a little bit more data driven, I need to be able to have those numbers through. So what we're looking at here is we're looking at what SAMHSA defines as what you should be measuring. And what I want to talk about is, remember, in SAMHSA's model, we're really talking about a two-person team that's working street level that doesn't include law enforcement. We can talk, and we will actually talk, and we benchmark about what the differences you might see between a civilian mobile response team and an embedded or a co-response with law enforcement mobile team, because you're going to get some different outcomes. And we'll certainly talk about that. But the first five are really all SAMHSA says. How many people are you serving per 8-hour shift? What's your average response time? What's the percentage of calls that you get to within an hour and that you get to within 2 hours? What's your longest response time? And what is your percentage of mobile crisis responses resolved in the community? You're going to hear me use the term community stabilized a ton. What community stabilized means, it's a very important indicator, is that I go out and I see somebody and I don't need to take them to a different level of care. I can basically support them in getting stabilizing so they can stay where they are, whether that's at home, whether that's at the shelter, whether that's at work, but I don't have to take them to a higher level of care or take them away from their natural support systems. Now, additionally, what I'm going to go ahead and say is that if you're running a mobile team, all of that is good, but I still need to know other things to see how well my teams are doing and how efficient they're doing. First and foremost, time on scene. Can be widely varied. Once again, it can depend an awful lot on what your system is. It can depend an awful lot on what your policies, procedures are. It can depend a lot on what the culture of the agency is going to be. And I have seen it go from 2 hours to 5 hours. LA County currently has about 5 hours. And we know the reasons for that. Some can be overcome, some can't be. In Maricopa County, average time on scene is about 90 minutes, 75 to 90 minutes. And there's reasons for that as well. I want to focus on what my involuntary commitment rate is. And that can be widely, 75% I've seen in some communities. In Maricopa County, it's 3%. Now, there's a lot of reasons for that as well, and we'll talk about that. PD co-response rate, we'll talk a little bit about what those numbers should be. But these are the times when a mobile team says, I have a public safety issue that I'm dealing with, and I need law enforcement to come out here and provide safety and security while we are doing our intervention. And I really want to focus on client satisfaction. And that is the community, the police departments, the fire departments, the EDs, the folks we work with, the stakeholders, as well as the individuals that we serve, those clients. So these are the ones that we want to start to take a peek at. And if we go one further, I'm going to go ahead and talk a little bit about some of the indicators you may start to think. So if we go one forward, it's going to look a lot like this slide. So what I'm going to, this is actually good. Let's go ahead and jump here. We'll keep with this one. So this is something that I've put together while I've been doing consulting. This one right here, I've sent up to Oregon. I work with the state of Oregon on a complete system redesign, mobile teams, call center, facilities, residential services. And for Oregon, these are the numbers that I'm thinking about currently. And I want to just think a little bit about how we utilize that. So first and foremost, I'm going to need to know total number of people served. So that wasn't in the SAMHSA guidelines. That wasn't in the guidelines that I kind of talked about, but that's just one of those common numbers that on any base, I want to know what my service units are going to be. How many people am I seeing? And what I want to go ahead and do is I'm thinking about a community. I want to go ahead and I want to think about how many folks should we be serving? Now, my initial target is going to be how many people did I see last year? What I can also tell you, though, is that if we start really looking in aggregate about how mobile teams across the country get deployed, if you've got 100,000 people in your community, you can anticipate seeing 768 of them in a mobile team per year. So if I've got 200,000, I need to multiply 2 by 768. That's going to be your optimal. That's going to be really if we're firing on all cylinders, if we're sending a mobile team every time it needs to go out, if I've got the teams available, that's what I should be getting. Now, what I can tell you is there are very few mobile teams across the country who are getting 768 calls per 100,000 in population. But at some point, 5 years, 6 years down the road, as we integrate 988 in, as we start to utilize some of the financial supports that are coming in, we're going to start seeing that. Average time on scene in Oregon, I think should be under 2 hours. In LA County, I think it should be under 4 hours. I think it should be under 480 minutes or under, 240 minutes for LA County. Transport is an issue in LA County. The drive time is an issue in that. They've got a high percentage of folks that are on 5150s. That takes a little bit longer. But what I'm going to say nationally is I think probably under 120 minutes time on scene is going to be probably the one you're looking for. So then we start looking at response times. So nationally, what we think about, and when we think about response times, we think about response times in aggregate. So if I see 1,000 people, I'm going to take all of my response time, add it up, and divide by 1,000. If I'm living in an urban area, that time should be under 60 minutes. If I am living in rural or frontier, it should be under 120 minutes. And this is what has become kind of nationally acceptable standards. The challenge I think you run into with some of the rural and frontier is you always hear about, well, we might have to drive 50 miles to go see somebody. And I agree. Sometimes you're going to have to drive 50 miles. I don't think it's the drive time that becomes the issue. I think it becomes the lack of teams that you may have. If I've got one team running 24/7, I need 4.2 teams to do that. If I've got a team that just went out on a call and somebody calls 2 minutes later and needs a team, they're probably waiting 120 minutes before that first team clears that scene and goes to the next one. What we do see about drive time is that historically, even in rural and frontier, there's a lot of calls that are just 3 minutes, 3 miles down the road because everybody lives in one town and you can go from one side of that town to the other side of that town in 10 minutes. But you do get some of those outliers. But what I will say is urban response time, anything over 60 minutes in aggregate is definitely a problem. There's really not an excuse for it. And in rural and frontier, I think 120 minutes is, I think it's generous. And I actually think it's doable if you have a focus on how to make that happen. But then what, based on SAMHSA guidelines we want to look at is how many calls are responded to within 60 minutes? And it should be about 85% of your calls. What I don't want to do is have one call take 5 minutes to get out there, another call take 120 minutes to get out there, and say, well, we got an average of 63 minutes, so everything's pretty close to being well. That person that was waiting 2 hours, it's a problem for. I want the majority of my folks to be able to see within 60 minutes. I really want everyone to be able to be seen within 2 hours. And I also want to start tracking my longest response times. Now, granted, it still should be under 120, but what I do know, there's going to be a few that are going to be over there. So I look in aggregate, but I also want to break it down to actually what's happening the majority of the time. And in the majority of time, I want calls to be answered and out there within 60 minutes. What we do see in some communities is it may be a 4-hour or a 6-hour lag time. It's tough for me to start saying that somebody's truly in a crisis. They can wait 6 hours for a mobile team to go out. So it becomes a little bit more difficult to justify some of those things. Either I'm not doing crisis work because there's such a long lag time, or I am doing crisis work. And if somebody can wait 6 hours, then maybe there's an alternative to a mobile team going out to where they are. The biggest one that we do tend to see is mobile crisis responses resolved in community. And what I'm going to tell you is that I've seen those numbers all over the board because nobody tracks them the way that they're supposed to. So as you're thinking about responses resolved in community, you've got to think about the folks that you see. In SAMHSA's model, you will see anybody, anytime, anywhere. If I take a look practically at the overwhelming majority, 90% plus of agencies that work mobile teams, they have exclusionary criteria. And I will talk about a state, I won't mention them by name, but I went and I interviewed and reviewed their mobile teams, and they were proud of their 92% response or their 92% community stabilization rate. Well, I worked in Maricopa County. When I was in Maricopa County, we were averaging probably 75 to 78%. And couldn't quite crack more than 78% no matter what we did. Money, threw more teams, into it, try to come up with different, dispositions that we could come into, increasing the training, couldn't get there. They were very proud of their 90% plus community stabilization rate. So when you start to break it down, what's actually happening? Do they have a stronger system? Do they have better aftercare and disposition? Absolutely not. What they wouldn't do is they wouldn't go out and see anybody who was intoxicated. They wouldn't go out and see anybody who didn't call and specifically request a mobile team to come out and support them. They wouldn't go out and see anybody with intellectual or developmental disabilities. They wouldn't go out on certain cases because they'd seen them already 4 times that month. So really what they had was strong exclusionary criteria. So the end analysis, who were they seeing? They were seeing the walking well, and they were keeping them out of the hospital, of course. But if I take a look at that 75 to 78% that we would see in Maricopa County, we're seeing folks that are intoxicated that their friend called for. My friend Jamie is drunk, he's angry, he's screaming, he's talking about suicide. That would never get a mobile team in Utah. That would get a police response. In Arizona, as long as you can keep them safe until the mobile team gets there, it's going to go ahead and get a mobile team response that's going out there. So as you're thinking a little bit about that mobile crisis response resolved in community, once again, that community stabilization rate, don't get excited if you're over 70%, if you have a lot of exclusionary criteria. And when I talk about that exclusionary criteria, it could be written or it could be culture. So I know a lot of times supervisors say, we don't have any exclusionary criteria. And I talk to the overnight dispatcher and they tell me 4 or 5 things they don't go out on. So 70% is what you're looking for. Exemplars in the community are going to be between 75 and 78%, but you got to be talking apples to apples and oranges to oranges, or else that number means nothing. It's something that's good on an annual report, something that's good to your funder, but in truth, you're not really supporting the community. You're seeing the healthiest of your community and getting good outcomes. The next level, mobile crisis responses requiring a higher level of care. It's going to be the inverse of your community stabilization. So if I go out, I can say I've really got two dispositions. Either I'm able to keep somebody in community with wraparound supports, or I've got to take them someplace to provide extra layers of safety and security. So if it's one or the other, if I'm stabilizing 70% of the folks in community, that means 30% probably are going to a higher level of care. If I'm stabilizing 50%, that means 50% are probably going. So we're looking at over 70% for community stabilized, and the inverse is going to be the under 30% that are able to, they need to go to a higher level of care. The other thing I want to start taking a look at is responses requiring an involuntary hold. It's going to be under 10% in most communities that actively utilize mobile teams a lot. If I take a look at certain counties that I know in California, the only time a mobile team tends to go out is when somebody needs to be placed on a 5150, and they're running 75% of the folks they're seeing are being placed on a 5150. It's almost the preferred outcome. In various levels, it's almost the easiest. It feels a little bit safer. And a lot of times what those teams tend to look like is they're going out to do an assessment to see if somebody meets the criteria for a 5150. And they're not quite thinking about, can I stabilize this? Can I find a way to go ahead and support this person to stay in the community? I'm really going out, spending about 45 minutes doing an assessment. And that assessment is going to drive what my outcome is going to be versus I'm going to assess, look for anchor points, start to try to stabilize, and then in 75 to 90 minutes, figure out if I can kind of get that done or not. Total number of transports to HLOC is higher level of care. And that means if I have to transport somebody, how many times is it my van that's transporting my peer and my clinician? And how many times do I need to bring either AMBO or police to go ahead and do that transport? Well, if my response is requiring an involuntary hold or under 10%, it should be only maybe 90% of the total transports that I can do, only 10% potentially that I need to have someone else go ahead and transport. Total number of transports, and then total number of requests for law enforcement involvement. So if I'm running a civilian team, once again, there are going to be times out there where I need to call for backup for law enforcement. And what I'm going to tell you is that number's under 3%. About 3% is okay. So when I was running mobile teams, I would look at that number. I would never look at it on a weekly basis. I would look at it on a monthly basis. And I would look for two things. If I had a staff that maybe had a 7% of the time, or a team that had 7% of the time that they were calling for police backup, that was a problem. They were probably a little skittish. Maybe they're working overnights. Maybe they get concerned when anyone has a diagnosis of schizophrenia, or maybe they get concerned when they see that somebody on the initial report coming in that somebody's been using crystal methamphetamine or cocaine or something. But I also get hyper concerned when I've got a team that maybe over the course of a month, and has maybe seen, 50, 60 people and have not called for police backup at all. Because I also get concerned that sometimes mobile teams think they're cowboys. They can handle anything out there in the street. And quite frankly, I get just as concerned when I've got teams out there that are not really thinking about personal safety or maybe overestimating their ability to influence somebody who maybe is impaired, psychotic, and so forth. So when I start seeing 2 to 4%, 1 to 5%, I'm usually okay with that. 7%, I get nervous about. 0%, I start to get nervous about as well. So really what I then take a look at this, and there's various things on this. And once again, this is a working document. If I'm doing consulting, this is something that I would end up pulling out and starting to take a look at. I said, well, who's actually accountable for those numbers? Because once again, as somebody who's run these teams, I hate to be accountable for somebody else's decisions. So total number of people served. In most communities, mobile teams are not making the determination as to whether they should go out or not. They're getting dispatched. So if I'm a mobile team provider, I really can't be accountable for how many times a call center dispatches somebody for me to go out on. I don't want to be in trouble with a funder for that. So that's something I do tend to track. The type of analysis is, what do I do with that information? I track it. Average time on scene, that is something as a provider I can be responsible for, especially if I get my initial targets right. I've got to make sure my teams are working fast, that they've got a cadence, that they're able to identify when they can support and when they can identify that they can't support. So what I can tell you is history. This is just Jamie talk, and I can't back it up with any documentation. 75 minutes to 90 minutes in Maricopa County is about the right amount of time on scene. Now, if somebody is on scene, if a team's on scene for 2 hours and they believe that additional 30 to 45 minutes is going to help somebody community stabilize, I'm all for it. But the reality is that after about 90 minutes, your likelihood of stabilizing somebody and allowing them to remain in the community isn't that terribly high. If I'm doing less than 75 minutes, chances are I'm not even attempting to stabilize somebody. I'm just doing assessment and paperwork. So I like that sweet spot of about 75 to 90 minutes. And if I've got teams that are historically out there 2 hours and 15 minutes for every call, I start taking a look at their numbers. I'd be really surprised if they were getting better than average community stabilization rates. And then you start thinking a little bit about what's your role, because you've got calls that are stacking. So average time on scene as a provider is something that I can take care of. What I generally tend to recommend to funders, and this is when I'm working with funders more than not, is start to track what that data is, determine what an appropriate initial target is going to go ahead and be, and then it's actionable. And by actionable, what I mean is the provider can be held accountable for that in whatever national way that goes. Average response time in urban should be under 60 minutes. Frontier should be under 120. I do believe the provider is accountable for that. They need to staff appropriately. They need to do predictive modeling of when they should have teams up and running. During busy times, they might need 2 teams. They might need to decrease their response team. There's a lot of things that they can do that. So it is actionable. So what we tend to see in most communities that run mobile teams, once the funding is kind of determined and the key performance indicators are in, it's up to the provider to go ahead and meet what those key performance indicators are going to go ahead and be. Calls responded to within 60 minutes, same thing. It's a provider's got to do that. Calls responded within 120, that's up to the provider. Longest response time, up to the provider. Mobile crisis responses resolved in community. Like I said, I'm saying over 70%. Exemplars would be 75 to 78. But who actually is, what's going to impact your community, your team's ability to resolve and community stabilize? What's going to be the skill set of your mobile teams? If they can engage, de-escalate, stabilize, they're going to have a better opportunity. But if you're living in a community that has no outpatient appointments, no support that's out there, I'm not going to be able to get anyone to see a psychiatrist for 4 weeks. There's no, some kind of community support as far as peer navigation or community building or anything like that. You probably aren't going to have quite the same community stabilization options, and your probably numbers are going to be a little bit low. So what I would do recommend then is we need to start tracking, seeing what it actually is, and then we can go ahead and start to base that initial target on that, and then start to stretch so that we're doing better. You can never be satisfied with what is. You've got to work to what's going to be. Responses requiring involuntary hold. Well, there's a lot of things that do tend to go into that. I think there's a lot of agencies or entities that are accountable for that. But at some point, you track, you find your baseline, you set your key performance indicators to better, and then you move on that. Number transport to a higher level of care, same thing, track and trend, and then it's actionable. Total number of transports, I just track that. I'm never going to get a provider in trouble for that. And number of requests for law enforcement officer, LEO stands for law enforcement officer involvement. We track that. The reason I say that don't hold a provider accountable for utilizing it too much comes back actually to lawsuit. So if the things that we measure, we manage, right? So if we're tracking data, and when I track data, I track it on agency and I track it on team. But the second I go back and I tell a team, you're calling law enforcement for backup too much, what happens that time they don't and somebody gets hurt? All kinds of trouble. So really what I'm going to talk about is you can call law enforcement, officer anytime that you feel unsafe. But once again, if it's more than 7%, I really kind of want to know why. I want to do a little bit deeper dive. I'm not going to say you can't, but really what I'm starting to look is, are you somebody that really shouldn't be working night shift? Are you really just typically scared of folks that have substances on board? Are you scared by anybody that, is homeless? As you guys out there doing mobile teams, you understand, we look for danger to others, DTO, danger to self, DTS, DTO, danger to others. But the folks we work with mobile teams, they're STO, scary to others. A good percentage of them are scary to others. Good mobile teams can kind of identify the difference between scary to others and danger to others. So this is what we look at. And I just have notes about where some of these things come from, national guidelines. Maybe there's multiple exemplars around there. A little bit different as far as the responses requiring involuntary hold. If you're running police teams too tend to see higher acuity because they're willing to go into places that mobile teams will say send the cops first. But this is what I would end up looking at. I've got an outcome line, disaggregate by, I want to be able to break all my services down by age. I want to be able to break them down by ethnicity. I want to be able to break them down as many ways as I possibly can to ensure that I'm serving the community as well as we need to. And then outcome is just the number that we've got. So this is really how you start to look at it. And once again, I think it's really important not to look at just your agency, but look at your teams. So when I was running mobile teams in Maricopa County, we'd have 24 teams, that were coming in, working 10-hour shifts. I would start to look at not just my overall numbers, but each team numbers. And I'm trying to get my agency numbers up by making sure all of my teams are consistently hitting the benchmarks that they need to hit. So let's go to the next slide. And these are just things that I've run into. Understand how community resources impact KPIs. So ultimately, like I said, I can if I've got a host of options at my fingertips, if I could drop somebody off at an outpatient clinic and get them seen today and get an intake in today, I decrease my reliance on taking somebody to a facility. If I have got stable housing, temporary or permanent supportive housing solutions, I can find somebody who's homeless and suffering some challenges. I might actually be able to get them there and keep them out of a higher level of care. So just understand that, when you start looking at national exemplars like Arizona or the teams that I used to run here in Maricopa County, and last month they had a 72%. We've actually seen a decrease in community stabilization in Arizona over the last year. So they're at 72% last month. But as we start to take a look at that, understand just how your community impacts that. If you really have no resources, you may want to just start at 60 and say in 2 years, I want to get to 65. In 5 years, I want to get to 72. You've got to start to stretch that. What I am going to say about your key performance indicators is you have to be fearless and transparent with them. So I can tell you that last month, I'm going to go back and look at the data because I get the data. We all get the data in Maricopa County. Mobile teams dispatched to police 389 times last month in Maricopa County. Police called and asked a mobile team to come out. They had a 72% community stabilization rate. The month before that, they had a 72% community stabilization rate. Month before that, they had a 74% community stabilization rate. All of those data points that I'm talking about here, they had 2010 dispatches that they covered last month, 2010 times they went out there into communities. 140 of those folks were veterans. So we're keeping track really of all of this. And in Maricopa County, all of that data is transparent. Everybody has access to what those outcomes are. They don't have access to any, PHI, but they have access to what the aggregate data is going to be. So when all of your data is transparent, you can't hide. You find out where your problems are, and you have to start to improve them. So what I am really saying is be transparent, be fearless. I know it sucks. I've run programs where people come and say, why are your numbers in the toilet? But those numbers never change if you keep them in the dark. They just don't. So they've got to be transparent to the community and what the community response is and agency. What I end up doing when you have multiple teams is you're going to have some teams that are inherently stronger than others. They've got better engagement skills. They know the community a little bit better. For whatever reason, they're going to just get better numbers. I generally tend to have my folks that are doing well. I use that as an exemplar of what is possible. So if I've got a team that's getting a 67% community stabilization rate and one that's getting 50% over the course of month and month, that one with a 50% can't say that's as good as it gets. I've got somebody getting a 68%. I know it's as good as it can get. 68 may not be as good as it gets, but I know it's at least doable. And then what I do tend to do is I tend to utilize those staff as my trainers for other ones, because they're going to come at it from a success viewpoint of what is potential, what's possible, and probably what's best practice to go ahead and meet those numbers. Nothing better than you going to a mobile team and saying, we've got a new team coming on board and you're going to spend 2 weeks training them. Focus on process. Time on scene, and really what I want to focus, time on scene is a function of engagement and paperwork. I go into communities and they say, well, we've got 3 hours on scene. And I start looking at their paperwork and it is oppressive. It's an hour and a half of just paperwork and just redundant and duplicative and things that apply nothing to the crisis. If you are running a team, you've got to focus on streamlining that. An intervention should be 75 to 90 minutes. And about that should be about 45 minutes of assessment and paperwork and about 45 minutes of of engagement. If you're running different numbers than that, it's not your team, it's your system, it's your process that you need to jump into that. Once again, I look at data in aggregate. It's always cool to take a look at what my numbers are today, but it's variance. I can have a really good day where today 83% of the folks were able to remain in community, and then tomorrow it's 61%. I start looking at it monthly, and once again, start to celebrate these successes. Little changes are hugely impactful. So they had 2,000 people that were seen last month, 2010 or 2001. Let me go back to the numbers here. They saw 2,010 people. So basically, a 1% change in a community stabilization rate means there's 20 people that didn't end up in a hospital or psychiatric facility just by having a 1% better community stabilization rate. Well, if you think about how much an inpatient hospital costs, if that's what your drop-off point's going to be, episode of care there could be, $11,000 if you're looking at a, $1,200 a day and a 8-day length of stay. Could be a 10,000, 11,000. That 1% that your teams are doing better could save the system 200,000 in unnecessary inpatient hospitalization just by getting 1% better. So celebrate that success. Increments have huge impacts, especially in larger communities. But what you really need to start doing is really focusing on finding your low-hanging fruit, getting them a little bit better, identifying that people are getting better, knowing that they're doing the right thing, and then keep stretching toward goals to get you a little bit better each and every way. So I think we might have time for some Q&A.
If someone absolutely refuses our engagement and or interventions offered, have they been, quote, served? Does response time include documentation?
All right, that is a great question. And I guarantee you there's multiple people who are thinking that exact same thing. So what I'm going to come back to is I'm going to come back to working in the US, and it's a little different when you're working in New Zealand. It's fairly similar when you're working in Australia. So let's say I go out and I'm on scene and somebody refuses to talk to me and I drive away. If that person commits and dies by suicide, am I still accountable? And the answer is yes, especially in the US. You've kind of eyeballed. So the question, if they're refusing engagement, have they been served? As long as I'm still doing assessments with my eyes, saying that they're disheveled, saying that they're angry, saying that they're clenching and unclenching their fists, saying that they're visibly intoxicated, saying that they're visibly attending to internal stimuli, I do have data. I don't have a full assessment, but on some level, I'm still going to be accountable for whatever outcome tends to happen because I'm a licensed professional and I'm coming into scene to go ahead and support somebody. So I think a lot of times we run into the concept of, well, if they won't sign my consent form, then they're not a client. I have no accountability. They haven't been served. But you still keep that documentation, right? You don't shred it immediately and say, we just never went out. So yes, they have been served. Now, how you get that funded, how you get that reimbursed, completely different. Probably can't do that. But I do have ownership and accountability for that. So that would go into that's a person that I served, and you might have a refused treatment or refused recommendations. But what I can tell you is there've been dozens of times I've gone out, somebody's refused to sign, but I see enough that I need to put them on a hold. I work in Arizona. It's a little bit different. It's Form A, Form B. It's petition as opposed to a 5150. But within 5 minutes, I've got enough that I know my state mandate for holding somebody against their will met, start the work. So does the response time include documentation? It should. But what I can tell you is that your documentation should be electronic and it should be done collaboratively. And by that, what I mean is I hate when I see a mobile team documenting on paper. They've got their assessment, they're checking it off, they're writing in the margins, they're writing up, they're writing across, they're that, flipping the page over, doing that, closing a case, going back to the office, and now entering it all into the system. Completely wasteful. In Maricopa County, and like I said, we saw 2,000 people last month. Basically, I've got a 2-person team. So it's going to be a peer and a clinician, and somebody's going to be documenting while somebody's talking. So if I'm the clinician and I decide I'm leading that intervention, I'll be asking some of the questions. My peer is actually going to be typing into the system. Now, granted, my peer can't sign. I'm the one that's got to sign, but that documentation is starting to come in. I can then clean it up as I'm heading out the door. So when you're doing that level of electronic 2-person concurrent or collaborative. They'll call it concurrent because at the time, or they'll call it collaborative because I'm doing it with the guests that I'm serving. Then I'm in a position that as I roll out after my 90-minute intervention, I'm hitting done, I'm clear, and I'm ready for my next thing. I'm not going back to the office and trying to catch up on 4 cases before I go home and squeezing into overtime. But once again, that's tough. You got to set your electronic health record. You've got to train for that. It's got to be the expectation. And what I can tell you is I know a lot of, old school clinicians that don't want to make that switch. They like paper and pencil. They feel they're more flexible. But what I can tell you is when you do it enough, you get good at it. You're just as good with a laptop as you're going to be doing it the other way.
Excellent. Jamie, thank you so very much. I do encourage people, if you have additional questions, put them in the chat. We will send them to Jamie. This is, as we said before, only number 3 out of 8 sessions. We hope you will continue to come to these sessions. I just want to reiterate again to folks that they have this incredible mind in you as a partner on the Care TA Center, as you are the training and technical assistance expert in-house that we have on mobile crisis units. If people want to submit a TA request at no cost, they go to our website, Care TA Center, which my colleague Ande will put in the chat lock, please. And we are thrilled to pair people with you, Jamie. I can tell people that the TA request that Jamie and his colleagues at RI International have responded to in the past have been some of the most popular TA that has been provided. Just like you saw here today, Jamie is just a phenomenal wealth of information. And what's nice is that he gets to the point. He just tells you the thing. And it may or may not be what you want to hear, but he's telling you from an incredible amount of expertise and experience. So please do go to that website link. Ande has put it into the chat. Place a TA request. You can ask for Jamie specifically, or you can just let us know, I've got a general question. I'm not exactly sure who the right person is, but we will gladly pair you up with a subject matter expert. And I see that these responses are continuing to come into the training feedback form. We're at the end of our hour. Jamie, I always feel like there's not enough time. So thank you for getting so much information into a short period of time.